Please take your seats so we can start. Sorry. Good morning, everyone. Welcome to day 3 of this fabulous ReAct Network Conference. I am Lauren Jankelowitz. No one can pronounce my surname, which gives me permission to butcher all of your names when I introduce you. Apologies to the panelists, just in case. I am from GARDP, which stands for the Global Antibiotic Research and Development Partnership. And I'm from the South Africa office, which has grown from strength to strength in Cape Town and Johannesburg, South Africa, but we work across sub-Saharan Africa. And so we have started to anecdotally call ourselves during this conference GARDP Africa. What I wanted to tell you is that there was an announcement late yesterday that is important for GARDP and hopefully for all of you. And that is that the company Venatorix has applied for FDA acceptance and priority review of a new drug application for a drug called cefepime taniborbactam. Can never be a simple drug name, but always a complicated one for us to learn. It is a beta-lactamase inhibitor antibiotic, and it treats complicated UTIs in adults. And if this is approved, it means that GARDP will have distribution rights in over 60 countries, low and middle income countries, many of them within Africa. And so that is some good news that I wanted to start this morning with. This is a session which will cover research and development as well as access. And just to start, we're going to play a 2-minute video that will just give you a sense of what it is that GARDP does, and then we're going to move into the program. So over to the AV team for the video.
Antibiotics are the foundation of modern medicine. They have protected us against harmful bacteria and extended life expectancy by 23 years. But their power is running out. Antibiotics have been used so extensively that many are losing their ability to fight bacteria. No one is immune. Drug resistance is a global health crisis, and it's happening now. Dr. Kruger doesn't have the right antibiotics to treat her patients. Melissa, a healthcare worker, is alarmed by the spread of supergonorrhea. Nurse Judith knows that standard treatments for sepsis are failing. Every day, life is on the line. Effective antibiotics save lives. Oram could not have survived without them. They saved Astrid's life during childbirth. Hilary knows that antibiotics are key to cancer care. Everyone has a part to play. Researchers, scientists, industry, civil society, communities, governments, policymakers. GARDP is committed to driving progress in antibiotic research and development. Together, we can help develop new treatments for drug-resistant infections and make sure that they are accessible to everyone. Join us.
Thanks very much for your attention during our video. It is now my pleasure and privilege to introduce our first speaker and my fellow colleague from GARDP, Lebogang Tshehla. Lebogang has been working in the clinical research industry for over a decade in both large and small pharmaceutical companies. She's currently working for GARDP as the clinical trial manager, overseeing all our clinical trials in Southern Africa. And these include trials and studies aimed at improving treatments for neonatal sepsis, drug-resistant gonorrhea, and serious bacterial infections. Lebogang has an honors degree in medical microbiology and a Bachelor of Sciences in Medical Sciences from the University of Limpopo in South Africa. Over to you, Lebo.
Thank you, Lauren. Good morning, everyone. Yes. Okay, I think we are gathered here. Can you hear me better now? Okay, go. Well, I believe we are all gathered here because we all believe that AMR is an issue for all of us. And I think it's very crucial that we really invest in clinical research to really understand this phenomenon, as well as come up with strategies to fight this disease. And today I'm just gonna be sharing on the highlights that GARDP has been doing in investing in clinical research in the AMR. Firstly, I just want to tell you who we are. We are DNDi GARDP, Southern Africa. We were co-founded by GARDP, DNDi in 2018, and we started our operational in 2019 as a non-profit organization in Southern Africa. We have about 22 employees, which 17 are permanent, and we have several expert consultants. And what we do, we work with several partners on developing treatments and ensuring that there's an access on those treatments. It's DNDi and it's GARDP, and DNDi stands for the Drug for Neglected Disease Initiative. And they do several clinical trials focusing on the neglected diseases such as the sleeping sickness diseases, malaria, HIV, and many more other diseases. For the Southern Africa offices, we really focus on HIV, which is on the pediatric HIV as well as the advanced HIV disease. With the pediatric HIV, we're really supporting on the access on the ARV treatment for children living with HIV. We try to introduce children-friendly antibiotics. We have done several. We have done several ARVs. One of them, which is quadrimin, which has been recently approved by SAPRA to be used as an alternative treatment for HIV in pediatrics. And with the advanced HIV disease, we're also developing, new formulations for cryptococcal meningitis, understanding that it's really a killer if it's not treated. And the current formulations are either expensive or they're not user-friendly. So our aim here is to actually, develop a formulation that is gonna be more user-friendly. And when it comes to the GARDP, which stands for the Global Antibiotic Research and Development Partnership, it was founded by WHO and DNDi, And this is after the World Health Assembly have, declared the global plan on the antibiotic resistance. It was established in 2018 as a Swiss foundation. And to date, they have over 50 employees globally, and they do have some networks. One in Northern America, we have representation in Australia, and we have GNDI GARDP Southern Africa. And we also are associated with regional DNDi offices in Japan, Malaysia, Kenya, as well as India and Brazil. As GARDP, we really, we do see that, superbugs are emerging everywhere, and they are really very smart, and it looks like we are losing the race, and therefore we really need to stand up and be innovative by finding new antibiotics. There was a data that was collected in 2019, which said that about 1.3 million people died of antibiotic resistant infection, and about 4.9 million people, died on associated deaths on antibiotic resistance. And when you look at this figure, it's actually more than, the number of people have died on COVID for the past 3 years. So this is really, it requires an agency, and it's really been grabbing the headlines everywhere around the world. We have, headlines from BBC, from City Press South Africa, and from Financial Times. As GARDP, what is our vision and our motto? We really do believe that infections are treatable for everyone and everywhere, and hence we are working with our partners to accelerate and access and ensure that there's access to those treatments of the drug resistant infection. And our portfolio really addresses the WHO priority pathogens. Just to name a few, is Neisseria gonorrhea, the E. coli, the Ebola, and others. We also look into, we also prioritize on the bacterial infectious diseases that have a burden AMR, which are clustered as a sepsis and sexual transmitted diseases. And we also look into different groups such as neonates, pediatric, and adults, and we also prioritize on the geographics where the burden is mostly affected. We have several programs that we are actually dealing with. We are doing the STI program. We are doing the children antibiotics program, which is divided into two, which is the neosepsis, as well as the pediatric development. And we also have the serious bacterial infection program. So with the STI program, our aim here really is to develop a treatment that will address the burden in the STI, and focusing really on the drug resistance gonorrhea as our initial focus, and then we look onto other pathogens as well. And our objective here really is to develop the drug that will be covering the emergence of the ceftriaxone resistant strains on the gonorrhea, and also develop a treatment paradigm that aims to slow the rate of resistance, and also to develop a novel access pathways at the national level to ensuring that there's an affordable and quality and reliable diagnostic and treatments to meet the public health needs. So in the STI program, really, we have run several studies. Recent ones being, we've done a bioequivalent study in Germany, and we are currently doing prevalence study in Thailand, and we just concluded the interventional study, which was a global study where we were testing the zoliflodacin product. And with the zoliflodacin product, the study was a phase 3 study which was conducted in 5 countries: the USA, Thailand, South Africa, Netherlands, and Belgium. And we managed to recruit about 943 participants. And we are currently just analyzing the data. We are hoping to get the results towards the end of this year. And when it comes to the serious bacterial infection program, our aim here is to really find new treatments for adult and pediatric, and our focus is really on the critical pathogen. And our aim here is really to collaborate with the Venatox, which my colleague just really mentioned earlier today, the good news, to develop the Ceften as a potential treatment for patients living with infections due to the carbapenem-resistant pathogens. With a serious bacterial infection, we are currently also doing a surveillance study that we are doing in collaboration with NHLS and NICD. And our aim here really is to we have picked up that there is a little bit of a gap in terms of data of the CRE in the Southern Africa. So we're trying to get a data to see, how much CRE we have in this southern part in South Africa. And we are currently also doing, in parallel, we are doing an observational study, which really our rationale here is to collect and analyze the data of the people that are being treated for the CRE. And our primary objective here is to really understand the microbiological diagnostic procedures and the clinical management of CRE, and to also understand the clinical outcome of the participants that have been enrolled in that study. And we do have a secondary objectives as well, and one of them is to describe the epidemiology of the CRP infections, and also to describe the healthcare resource utilization efficacy and the outcomes for the patients who have been treated for the CREP infection. And also we try to build a capacity for those sites that are conducting the study. The study has been conducted in 2 countries, in India as well as South Africa. We've got 5 sites in South Africa and 6 sites in India. And we're looking into enrolling about 330 participants globally. And to date, we have recruited about 50 participants globally. And then when it comes to the children antibiotics, as I mentioned earlier, that we have the neosepsis as well as the pediatric development. So we're currently doing a lot of neosepsis studies. And one of the reasons is that, we've noted that like over 240 newborns, they die due to drug-resistant sepsis. And I think this is just, this can be prevented. And one of the reasons is that, there are limited options to option treatment for this vulnerable babies, and as well as most of pharmaceutical companies, they don't really invest in children antibiotics. So we have done an observational study which concluded in 2022, and our aim here was to collect the data for 28 days to understand the routine treatment of the children who have been diagnosed with clinical sepsis. And our objective here was to actually characterize the death rate, to collect the physiological observations, and characterize the clinical presentation and the outcomes of the infants with clinical sepsis, and as well as collect information on the antibiotic dose, on the duration, to inform the AMR stewardship practices. The study was done in 11 countries, and we enrolled 3,200 babies. And from this observational study, really our key message was that 1 out of 5 babies died due to sepsis. And then we did understand that most of the hospitals, they really deviate from the WHO recommended regimen. And there is no standard of care regimen that most infants receive as a first line. And most sites, they actually, they run into using the second line drug instead of the first line drug. And the reason mainly being that, the WHO guidelines, they've been noted 20 years ago. Even though there is a resistance, they have not been revised. And then with that, we really embarked into an empiric treatment trial called neosepsis, one study, which really our aim here is divided into two parts, which is a part 1 and a part 2. And our part 1 really is to evaluate the dosage of the safety of fosfomycin as well as Flomosef, which are the two drugs that we are introducing. Fosfomycin, it has a recommended dosage in the neonatal group, and it has a recommendation that it must be taken with another antibiotic, whereas Flomosef, it has a approved dosage in the neonates. However, it's been used in Korea, Japan, and Taiwan. And then we have the part 2, whereby we're going to be really evaluating the combination of these antibiotics. We're going to combine it with amikacin, and we're going to evaluate it, and then we're also going to try and rank the novel regimen with the existing WHO recommended treatment. With the empiric treatment, the part 1, we're going to be enrolling about 60 babies. The study has been carried out in Kenya, Kalipo Hospital, in South Africa, Baragwanath, as well as Tygerberg. And for part 2, we're looking into enrolling about 3,000 babies. And we are currently doing feasibilities for sites in Bangladesh, Brazil, Uganda, Ethiopia, India, Malaysia, Kenya, South Africa, Philippines, Morocco, and Tanzania. And with this study, we are partnering with the Penta Foundation, the MRC Clinical Trial Unit at the University of College London, the St. George's University of London, as well as University of NREP. And thank you so much.
Thank you very much, Lebo. We are going to take some questions afterwards. What we're going to do now is we're going to move on to another colleague of mine, Kim Faure. Kim has more than 20 years of experience and knowledge of healthcare strategy development, public health policy and regulatory frameworks, and patient safety quality assurance systems in South Africa and Africa. She's worked in both public and private healthcare sectors in South Africa, as well as the mining sector, and as a consultant for various NGOs, especially in Africa, on AMR and NAP design and implementation. And Kim knows most of the people here at this conference, I've noticed, over the past 2 days. And so I'm going to welcome Kim up to talk to us on access.
Good morning, everybody, and good to see you all back. So I'm going to be talking about ensuring access so that we preserve the power of antibiotics. And I'm going to be highlighting the 2 access programs that GARDP is busy running, both in Africa and in other countries, one being Secure and the other one my colleague Lauren runs, called ReAct, which is in Kenya and South Africa at the moment. So Lebogang has taken you through some of the work that GARDP does, but now what I'm trying to show you is that the work we were doing was in the clinical phase 3 trials. Now we're looking at the path that goes on from that, which is how do we ensure the access of those antibiotics, not just the ones in the GARDP portfolio, but other access antibiotics to the rest of the low and middle income countries. So that's the GARDP portfolio, just because Lebogang didn't show you all of the details. Some of these are being reserve antibiotics, but as she mentioned, on the neonatal sepsis side, and the STI side, we've got some what we would call generic or access antibiotics, which are critical for first-line treatment as well. So the 3 parts of our access program is the one around ReAct, which stands for Pathways to Reshape antibiotic access collaborative teams. And that is a novel way of making sure that we have an introduction strategy for new antibiotics to come into a country. And that was part of the GARDP portfolio antibiotics. The work that I'm specifically looking at is global access, which is called SECURE. And SECURE is looking at access specifically for all antibiotics essential to the treatment of drug-resistant infections in low and middle-income countries. But GARDP also has a global impact, and that global impact is around policy and advocacy to support aspects that will improve the reporting and the understanding and the transparency of information related to shortages, but also transparency of information related to pricing of antibiotics. So just to quickly give you some background on the pre-act, so pathways to reshape antibiotic access collaborative teams. As I mentioned, this is being piloted in Kenya and South Africa using cefiderocol as the access project. And it's specifically looking at how do we create the mechanisms for introducing new antibiotics into a country. It covers manufacturing. So how do we make sure that we have an affordable and quality assured product with the license requirements from a manufacturer? How do we get and support the countries to register that product? And part of the registration would be the requirements for how that product gets used and distributed into the different levels of care so that we can contain the stewardship component. The major work is around the implementation, where there's partnerships between GARDP and the in-country experts, all looking at how do we make sure that the doctors understand and know how to use the drug? How do we make sure that the drug gets put into the system in a safe, stewarded way, including gathering evidence to update treatment guidelines, placing that drug on the essential medicine list for the country to ensure that it is part of the procurement processes and becomes part of the availability of medicines. Other pathways, we're calling it a glide pathway for the new drugs, but the key bit is around policy and legal environment assessments, making sure that we understand what the country has in order for them to bring that drug in. There's a lot of leveraging of best practice and creating a collaborative community so that we can support and share on initiatives and quality improvement between the countries. There's a priority around operational research, making sure we understand the evidence to develop protocols for those drugs to be used in the countries, and working directly with civil society and all the mobilizing partners to make sure there's political will and the ability to bring the drug into the country safely. So now we're going to switch a little bit onto overcoming barriers to access. And as we've heard from many of the speakers, the challenges of antibiotic and AMR includes the fact that countries such as the ones in Africa don't necessarily have access to the antibiotics they need. So SECURE is supposed to address specifically where we have challenges around drug shortages, which disproportionately impact our antibiotic and antibacterials. And so the SECURE mission and vision is to ensure access to essential antibiotics to support countries for the drug-resistant infection and the pandemic of AMR that we're experiencing. So the portfolio for SECURE is quality assured antibiotics, and there's two main categories. The one is around the new antibiotics, especially reserved to address drug-resistant infections. And by new, you see I've put a little definition at the bottom there. New is from the perspective of the country. So it might be a drug that's already registered by a stringent regulatory authority somewhere else in the world, but has not been brought to that country. So it doesn't necessarily mean it's a reserved antibiotic only. And then existing antibiotics. So here are the antibiotics that are prone to repetitive, regular shortages, based on supply chain issues or other reasons for market failure that results in a shortage of the drug. Okay, so how does SECURE see this happening? Oops, sorry. Now it's gone too fast. Okay. So SECURE is not going to become another procurement entity. We're not becoming a new global fund either in terms of financing. We want to work directly with existing procurement entities to help support and coordinate countries from regions to come together and pool procure. we have started building some economic and financial tools to work out how can we make sure that the countries can finance these antibiotics in a sustainable way, with the whole perspective being self-sustaining and making sure that they are at the same time affordable. We are not compromising on quality of products at all in terms of the way that we want to get the mechanism to work. And we're not going to compromise on stewardship. So every antibiotic in the portfolio will have the support of responsible stewardship use, but at all levels. So prescriber level obviously is the key level, but it needs to be at policy level within a country. It needs to be at the level of the regulations that are set in when you register that product, and it should be at the supplier level as well. So we're trying to build the stewardship process that it's all-encompassing and not just in terms of prescriber. We've also realized that quite a lot of the procurement challenges that countries have and why there are shortages is they don't have transparency of information. So we want to create a market intelligence dashboard that indicates to countries who are the suppliers or who are the alternative suppliers when there's a shortage of a certain drug that occurs. And also specifically around the watch and the reserve antibiotics, giving countries the knowledge of where they can procure and what the prices are, and trying to look at transparency of pricing. I don't know if any of you looked at, there was a presentation done earlier from Mark when he showed the prices of certain reserve and watch antibiotics. And that's the price in South Africa, but I can tell you the price in India can sometimes be a quarter of that, or the price in Morocco can be double that. So why, for the same drug, have we got massive disparities? Because that increases the issues of access. And then, as I've mentioned before, on the pre-act, looking at the evidence generation, making sure that we know exactly how that drug must be used, where it must fit into treatment guidelines, and then obviously monitoring resistance and consumption and use. I'm going to skip this one. Okay, so I want to show you how we see the mechanism working. So I'm going to start on the right-hand side with secure, where the little bubble is. So secure is going to be the catalyst for a number of things. So secure would look at coordinating countries that are interested to pool procure. It would contract with a procurement entity, so an existing entity. And I've been talking to Merfin about EPN, so that we've got an African-honed and addressed organization, but there are other entities that are looking at pooling in the various regions already. That mechanism, the procurement entity, would then do the direct work with the countries. In particular, it would make sure that the countries are able to forecast their antibiotic needs. So we're developing a forecasting model. We're making sure that they place their orders and get their payments done, and then supporting it with catalytic financing in terms of making sure that there's subsidies for countries where there's a very increased price of a drug, or making sure that there's volume guarantees to the suppliers to support the suppliers in being able to enter a market. Then we're going to make sure that we've got manufacturers that are diverse and are able to provide us with quality drugs. They would help support a regional stockpile, so there's always surety of supply, and they would then make sure that they deliver directly to the countries. So the benefits are from pooling on affordability. There's a mitigation of shortages because of the stockpiling. There's quality assurance of products because you've got a diverse supplier set and you've got vetted suppliers, but also you've got supply diversity, making sure that you've got the right type of suppliers who actually perform against their contracts. So to give you some idea, we took 3 different antibiotic archetypes for access, watch, and reserve, based on their specific barriers to access, which is the second column, either because of shortages or affordability, or because there's no introduction pathway. We then looked at what could be the purchasing options. How would we support in terms of the manufacturer side? And you'll see specifically volume guarantees on the expensive drugs, which secure would be the financer of the volume guarantees, not the countries. And then looking at how do we support the country to make it sustainable, either with minimal catalytic financing or with significant catalytic financing. And this is what it would look like. If we were to take a small, low-income country in Africa that is about 12 million population, and we added them into a 100 million population pool, so you've got to have pooling up to that 100 million level, Looking at an access drug, amoxicillin pediatric syrup, 30% discount, the country could save 1.4 million in 5 years. Watch drugs, azithromycin IV, $4.3 million over 5 years, a 37% potential discount on the average price. And Keftas-Avir used $0.8 million and a 60% discount on that drug. So in total, the country over 5 years can save 6.5 on just those 3 drugs. This is for one small country adding its inability to have buying capacity into a 100 million pool. Just think about if you made that pool even bigger, or if you added more countries and what the benefits would be on that. So I would like you to please go onto your phones and give me some ideas of what your challenges are with antibiotics. So can we stop the... Must I stop share on this side? Okay. So if you can go to menti.com, and the code is right on top, 83670262. It's right on top. So the code is 83670262. And for the first question, which antibiotics do you have access challenges with? I'm being very non-specific here. And you've got up to, I think I've got 3 or 5 options that you can put in. And don't worry about your spelling. 83670262. Yeah, if you can just...
That's this dialogue part.
There you are. Okay.
All right.
Perfect. So if you can see the spelling there, if you want to add to that spelling, it always helps. Then we get to see. Oh. Okay. Going to give you another second if that's okay. Lauren, are we okay? Okay. Has everybody had a chance to at least load one? You can just keep going. It will keep using it. And what I can do is I can make sure that it goes back as part of the conference summary, because I can PDF it and give you the results at the end. Okay, next question. Why is it not letting me? Can you move on to the next one? Thanks. What are the reasons for the challenges in access? So here I've been very prescriptive. Price or insufficient public health finances. The second one is supply chain shortages outside of your country. I'm not looking at supply chain issues internally. Not on the EML or procurement list. Not registered in your country. No mechanism to ensure safe stewarded introduction of the new product. And you can do more than one. You don't have to just choose one. You can choose more than one if it's relevant. Interesting. Okay. Kind of what we assumed. Okay, perfect. Can we go on to the next one? Thank you. And then the last one, would your country be willing to pool procure with countries in your region? And I've said, yes, if there's political support. no, or our regulations prevent it, or maybe. And here you can only choose one. Sorry. That's an interesting one. Okay. Alrighty. And then just as a last mention, if there are countries here that would be interested in having a more detailed discussion on secure, or potentially looking at how your antibiotics that you've got access challenges now, if you were to model within a pool procurement mechanism, how that would work, please contact me or contact Dr. Ali from WHO Afro, as he is part of our partnership, because we're working directly as a bilateral with WHO on this work. So thank you very much.
Thanks very much, Kim, and thanks everyone for participating in that mini survey. Now, yet another semi-South African, someone that has lived in South Africa for a number of years, but is also Canadian. I'd like to introduce Julia Bishop. Julia is a lawyer, and she holds a Juris Doctor and a Master of Laws. She focuses on strategic planning and decision-making operations and building meaningful partnerships at the AMR Policy Accelerator, which is housed within the Global Strategy Lab at York University in Canada. Julia has substantial experience in strategic leadership and in setting up and running programs in maternal, child, and adolescent health in sub-Saharan Africa. She's passionate about working towards ensuring good health and well-being for all. Welcome to Julia.
Sorry, thank you. Thank you to Lebogang and Kim for your really insightful and inspiring presentations. We're going to switch gears now again a little bit. I was a bit nervous when I saw I was speaking on a scientific panel. As you've heard from my background, that's not my area of expertise, but in retrospect, I actually think this works really well, because we've been talking a lot about the bridge between science and policy. And I think having these sorts of panels where we're hearing from a diverse range of stakeholders who come from different perspectives is actually really effective in showing how those links can be made. Kim just spoke about accelerating access to antibiotics. And I'd like to talk about accelerating access to policy solutions. You may have seen our logo here, the AMR Policy Accelerator, and wondered, who is that? Who are we? What are we doing? We're quite a new entity. We were funded by Wellcome in the beginning of 2021. But as Lauren mentioned, we are housed at the Global Strategy Lab, which has been around for much longer. So today I'd like to take you through a little bit more about who exactly we are, what it is that we do. We are a WHO collaborating center on global governance on AMR. And so I'll give you an example of a project that we're doing at the global international level, as well as an example more at the national level. And then finally, hopefully we'll come away with why it all matters and why we feel that the work that we're doing adds value to the work that you're all doing. So that's what I hope to go through today with you. So as I mentioned, the AMR Policy Accelerator is bridging the gap between AMR science and policy. And I loved your presentation yesterday, Dr. Chandri, about how important this bridge is. And hopefully we can be a brick in that bridge and on that path. So we are based in Canada, but one of our mandates is to partner with low and middle income countries. So one of the main reasons that I'm here today and that my colleague Sam as well is here is to meet, exchange, network, and learn from all of you, because that really is part of our core mandate. Another part of it is our academic and policy engagement piece. So we're kind of on both sides of the academic side as well as the policy side. We work with a lot of policymakers, but we are housed within an academic institution. So we very much see ourselves as having one foot in each pond. And then also we have a strong commitment to equity, diversity, and inclusion. There's been some wonderful sessions. I was in the session yesterday around gender and AMR, and there's some really wonderful work being done in that space. And I think we can all agree that a commitment to equity, diversity, and inclusion is a precursor, is mandatory for any policy that's going to be effective and be able to reach the populations that we all serve. Knowledge mobilization is kind of underpinning all of our programs. I think, again, people have spoken a lot about the need to disseminate the messages and the research that we're doing. And sometimes that can be a bit of a blockage point and something that we struggle with. So that's something that we really want to invest in and put thought behind around how can we disseminate these messages? How can we make sure that policymakers, that people, that youth understand the urgency and the importance of AMR. And finally, and this is maybe where we have a slightly different kind of approach or value add when it comes to the AMR and policy space specifically, and that's that one of our main mandates, and I'll speak through our programs shortly, is to provide rapid and rigorous policy responsive research. So what does this look like in terms of how we organize our programs? And some of our programs have started to span between these three different program streams. So when they were originally designed, it was very much three distinct program streams. They have started to mix a little bit, but I will speak about them as distinct entities because they are slightly different in nature. First of all, our advisory services program stream. And here, we start off by building partnerships by meeting with policymakers, by meeting with international organizations, understanding the needs that different countries and different organizations might be coming across. Because maybe you don't have a question right now, but maybe you'll have a question that we can help you with 6 months from now, 1 year from now, 5 years from now. So it's really about building those strong partnerships. And when a country or an organization has a question that requires evidence, but they need evidence in a short time frame. I think sometimes, research can take a long time by design. It needs to be thorough. It needs to be peer reviewed. But sometimes policymakers have questions that require much more time-sensitive responses. And how can we accelerate that access for policymakers to that evidence-informed research to help answer the questions that they may be coming across, whether it be with their NAP prioritization or specific questions that come up in their work. We did a project with the government of Bangladesh, for example, around knowledge, attitudes, and practices of pharmacists when it comes to AMR or antimicrobial access use. So that's those sort of like specific time-bound questions that governments come up with, and they can come to us and we can facilitate access to that evidence. And so what does the kind of output of that look like? One of the main things we have been doing is around evidence synthesis. So again, a policymaker would approach us with a question, and we would be able to provide them with the kind of latest research. I like to think of it a little bit, I don't know if anyone watches the program Who Wants to Be a Millionaire, but there's that feature of call a friend. So I like to think of us as that expert friend that you can call on when you get into that bind that you really need a quick but informed response for. We also provide policy options. Again, knowledge mobilization is something that you'll see running through our programs, implementation and evaluation, ethics and sex and gender-based analysis. So I was really interested in the presentation yesterday, Murphin, around gender and AMR, and thinking about how countries may now be thinking more about it after your presentation, after meeting everyone here, and whether there might be scope to work with any of you if you are thinking about taking a sort of a gender lens to your NAP or to certain elements of the implementation of your NAP. And finally, convening policy dialogues as well. Our second stream of work is around policy research, and this is maybe more a traditional research kind of focus. We work with our advisory board, which is chaired by Dave Sally Davies, as well as our research steering group to select really pressing policy issues around AMR. And then we conduct policy engagement activities aimed at framing AMR issues through a focus on One Health, working with expert groups. So we both have internal capacity, but we also look to our network of people who know more than us about certain topics to make sure that we're really bringing in the right people and that the right voices are there at the table. And lastly is our capacity building stream. There are a couple of different elements, but I thought I would just focus on this one because it may be of interest to some of you in the room, especially the policymakers. So this is my little sort of pitch to you. Next year in 2024, around this time, maybe sort of June, July 2024, we're going to be offering a 1-week executive level short course in Toronto, in Canada, specifically aimed at policymakers who come from a technical background. I feel like I've met so many pharmacists here, and I know that there are those of you from medical backgrounds, veterinary backgrounds as well. And this is a program or a course that's really designed for those people who come from a very strong technical background and are now moving into a policy role and may not have had that training, that exposure to the policy aspect of their position. So how do we help provide capacity development, exchange of knowledge, and learning between different people who are, we say executive level, it's not to scare people off that we need like the Minister of Health. It's very much aimed at people who are NAP coordinators, that kind of person who's at that level and engaged both in the policymaking space, but specifically around AMR. And the output hopefully will be to deepen understanding of policy levers and how to use them effectively. As I said, it will be hosted at York, but it's in collaboration with UNITAR, which is the United Nations Institute for Training and Research. So if there's anyone here who is interested, please feel free to let me know. It will be a pilot for the first year, so I can definitely give you information on what the application process would look like. And then what does our work look like in practice? So as I said, I'd like to give just a quick overview of a project that we're doing at the global level with the World Health Organization as one of their collaborating centers, and then also focus on a specific project that may have practical implications for, again, the policymakers in the room. Apologies to the researchers. Okay. So with the WHO, they've commissioned 3 policy briefs, one on gender and AMR, one on equity and AMR, and one on disability and AMR. So we're working with them on the first one there on gender and AMR. And what the WHO is hoping to do is provide practical country guidance for the inclusion of gender in human health policies, interventions, and monitoring as a first part. And secondly, to then integrate those recommendations into the development of the WHO's people-centered framework, which I think you heard about yesterday. I unfortunately wasn't in that session, but that's what it will be feeding into, and that will take the form of a supporting document. I was going to go through this, but I think let's move forward. So one of the projects that we worked on actually prior to the Accelerator launching was with the Canadian government on their national action plan. So they came to us with a large number of activities, I'm sure you can relate, and they really wanted to hone in on which were the key priority areas for them. And through that process, we developed a framework for prioritization. And I was so encouraged when I heard Dr. Martha speak about the importance of prioritization yesterday. I wanted to stand up and clap because it really affirms that this is something that is hopefully needed and hopefully of use to some of you in the room. And the Canadian government was able to incorporate some of the key themes that came out of this process in their NAP, which was recently published. And just to speak briefly about what this framework is, and this is a framework that we're hoping to pilot with a number of low and middle income countries. We have not decided on who those countries are yet. So if this is something that would be of interest, please reach out to me, whether it be this afternoon or after the conference. Let's keep the conversation going. So the way that it would work very briefly is that the NAP coordinator usually would give us a list of key activities that might be either in consideration for a NAP, or maybe you already have your NAP, but you're trying to narrow down which activities you really want to focus on, and which are going to be priorities for the implementation phase. We would then facilitate a workshop. I think we've spoken about how important it is to be context specific. And we, of course, I mean, we're from Canada. We don't understand all the contextual elements that exist in each of your countries. So we're really looking for the policymakers to come to the table with those activities, with that knowledge, to convene the important stakeholders across the One Health across the One Health sectors or areas, and have the right people in the room to have these conversations. And we would be guiding and facilitating that process, not coming in and giving advice about like, you must do this, this, this. It's much more about providing a framework for that discussion and guiding that discussion in a way that we have used in the past effectively. So the participants would then score all the key features for each activity. We would come back to you and be able to identify 4 large blocks in terms of activities that could be prioritized. We've got best buys, which are the most cost effective. We've got game changers, which are the most sort of transformative activities that you could do in your country. Equity drivers, so really embedding that equity element, and quick wins, which are ones that will get you the quickest win, as the name suggests. And then it would be up to the government to take those findings back and incorporate them into their planning going forward. So just to wrap up, I started off by saying I wanted to talk about who we are, what we do, and why it matters. I hope that's come through in my presentation. I've really enjoyed getting to meet and speak with many of you during the conference, and I hope we can keep the conversation going. I think we've heard this term accelerate a lot, actually, during this conference, and I think that speaks to the urgency of the issue of AMR. And we all need to play a part in accelerating, however that might be, whether it be access or policy solutions. We need to make sure that this is an issue that governments not only understand, but are moving quickly towards finding solutions for. And without further ado, those are my contact details if you'd like to reach out to me, and please follow us on our website for our newsletter. Thanks very much.
Thank you very much, Julia. I'm definitely going to be contacting you, one of the people that wants to follow up and chat a little bit about collaboration. Just to say that in this space of AMR, we need to be agile and be able to deal with change. And on that note, I'm going to ask Murphin to come up. We've got a slight change to the program, and he will just explain what that is. We'll take a little bit of a pause, and then we will hear from Evelyn online.
Thank you so much. Good morning, everyone. It's great again to see everyone here. We'll just pause a little bit, and the reason is that our host, the Director General from the Ministry of Health at the Zambia National Public Health Institute, who you have met the last 3 days, and was supposed to come and do the closure of the conference. Unfortunately, he will not be able to do that. He cannot stay beyond actually 10 o'clock. And he's got some pressing issues that he has to attend to immediately. But before he even comes and just says a few remarks, I would like to acknowledge the presence of Dr. Eriksson, who is the program manager for health and SRHR at the Swedish Embassy, SIDA. And as you know, SIDA is our main funder, and just wanted to give to say 1 or 2 words before the Director General can give us some remarks before he leaves. Dorcas? Yeah.
Good morning, everyone. Like Muffin said, my name is Dorcas Chiwanuka Henriksson, and I work as a program manager for health and sexual reproductive health and rights at the Embassy of Sweden here in Lusaka. It's a pleasure to be here, and my apologies, I couldn't attend on the first and second day. I'm sure that I do not have to reiterate the importance of addressing antimicrobial resistance, as that is a very important issue, not only for health for human beings, but also looking at global health and the health of the planet and animals. So I am very privileged to be here, and also that CEDA supports ReAct to carry on this very important work. And I wish you all very good deliberations. Thank you.
Thank you very much. I'll now call upon our Professor Chilenji to come and give some remarks.
Good morning, colleagues. Let me respect the protocols and just thank you all for your attention in this moment. I'm sorry that I'm not able to stay until the final closure of the conference, but just to reflect on what a moment this has been. And we need to look back a little and introspect and acknowledge actually that this is a strong emerging movement, and that the world of AMR is dependent on the people in this audience. Here on the continent, AMR is, or rather has been, grossly neglected. But I think with this movement, we are on the right trajectory, and I think we are getting somewhere. I want to recognize that this conference has brought so much into one room, so much expertise, so much experience, so much learning, and so many opportunities to look to in the space of AMR. I think that this conference has marked an important turning point in the space of AMR, at least from the lens through which we see this activity. A year ago, the topic and subject of AMR was neither here nor there for us here in Zambia. But today, as we speak, I think we can see a very clear path and a clear future for the sort of things that we need to do. Since the conference last year, much has been achieved in Zambia, and I think you heard from the presentations from my colleagues on some of the progresses we've made. But it is important and fair to recognize that many countries across the continent are actually making similar progress. And I think we heard from the few representations that have been presented in this conference on their national action plans and the activities that have moved forward. I think that it is important to recognize the One Health approach that is being embraced in moving public health forward in general. And I think this conference has done justice to that. I also observe that there is much activity under the One Health frame in terms of the human health side of things, the animal health side of things, but not so much activity on the environment and the plant side of things. And I think we should not leave that aspect behind as we forge forward with issues of AMR, because what we do in humans and in animals eventually ends up having an impact on the plants and also in the environment. And I think we must not leave those aspects behind as we move forward with these agendas. I want to also appreciate that in this conference, there are several students who have come from various universities who have participated through poster presentation, and that has been incredibly important in making sure that the current conversations on AMR are being carried forward, and we really appreciate that initiative, and we look forward to more because we need to make sure that the generation that comes after us are up to speed with issues that matter, and AMR matters. I want to also acknowledge that this conference has really brought much awareness to us. And I think that we have come to learn a number of initiatives that are moving this agenda forward. It has been pleasing to hear more about ReAct. It has been pleasing to learn about GARDP, about the Accelerator program, about ReAct, and the other initiatives that have been raised during this conference. And I want to encourage all the delegates to make sure that we take advantage of the opportunities proposed through these initiatives and move them forward. I want to reiterate that the subject of AMR is going to be pushed by the people who are in this conference. And I think if we sit back, these aspects will suffer. So we've got to pick them up and push them forward really, really hard. So let's take advantage of the networks that we are forming, the partnerships that we are forming, and let's not sit back and go back to life as usual, but let's take on every opportunity that is being presented here and move the agenda forward. The matters being presented concerning food procurement may sound complicated now, but it surely is going to be the way of the future in making sure that we can access medications and things that we need at prices that are not otherwise exploitative to the people that actually need those interventions the most. And again, it is up to those of us in this conference to rise to the challenge and do what we need to do in order to take advantage of these initiatives. So with those remarks, I would like to really, really thank everybody for coming all the way, for your participation here, and also a special thanks to the organizers, and particularly taking recognition of ReAct Africa, and an individual of note, our friend, Dr. Muffin Mpundu. We are grateful and we appreciate your initiative, sir. And with that, I will selfishly and shamelessly say that we are looking forward to the next conference next year. Thank you.
Thank you so much, Director General. It's a great privilege and an honor indeed for you, and also showing the commitment that despite your busy schedule, you stayed with us most of Monday, and you've graciously again graced us with your presence. We are very, very grateful, and to you, but also to the Zambian government at large. Thank you, sir, and we will excuse you. when time is right. I hand over back to Lauren.
Thank you very much. Thanks, Prof. And thanks for plugging GARDP and a number of our programs there for us. We are thrilled that we have made this kind of impact. I would like to introduce now Evelyn Wesangula, who is joining us online. Evelyn is Senior AMR Control Specialist, supporting the implementation of AMR National Action Plans in East, Central, and Southern Africa, with a focus on strengthening coordination, governance, AMR surveillance, and antimicrobial stewardship programs. Evelyn, I hope that you can hear us. We are going to get your slides up now.
Good morning, everyone. I hope you can hear me well.
We can hear you well. Thanks, Evelyn. Just give us a moment or two to get your slides up.
If you would please allow me to share my slides. Thank you.
Go ahead.
Thank you. I hope you can see my slides.
We can see your slides, just needs to be put into presentation. There we go. Perfect. Over to you, Evelyn.
Thank you. Thank you very much, and good morning, everyone. Thank you for the opportunity to make this presentation this morning. I also just want to thank ReAct Africa for inviting us to be part of this conference, and we apologize that we were not able to come in person and meet all these wonderful people and share in the rich experience that is in the room. I want to take on this presentation just building up on the conversations that have happened this morning from Lebo, from Kim, and from Julia. We ended actually the first session of the morning with a very great presentation on policy around MR, and also just building on to the DG's conversation on what this means for the continent, and just keeping the momentum going on antimicrobial resistance. So I'd like to share this morning on approaches for sustainability, and having listened from policy and listened from what's going on in research into newer antibiotics, and also just working around pooled procurement to ensure access to all these antibiotics in our different countries. I'd like to take on that aspect from an implementer's perspective. And before I do that, just a brief overview of who ECSA is. ECSA is the East, Central, and Southern Africa Health Community. This is a regional intergovernmental health organization. That means we actually came into force because of the request from member states. And you can see it is not a new organization. We will be marking 50 years next year in April. Currently, we have 9 member states that are blue on your map, but we work beyond the member states into countries that are orange on the map there. So the scope of our work is not just limited to the member states, because I think COVID has taught us a lot that we are only as strong as the capacities that exist in our neighboring countries. So that's why our work extends beyond the member states. So we are answerable to health ministers within the member states, and you can see that's the highest governing body that's responsible for setting health policies for the region and also defining health priorities, so which gives us a very good platform in terms of convening the health ministers to dialogue around issues that affect the different member states. And of course, responsible and also answerable to the advisory committee, which is largely made up of the permanent secretaries. These are the ones who sit with the passes or the monies within our countries. And of course, at the technical level, working with the directors within the respective ministries of health. So our priorities are broad, as you can see, and that's why I said, picking up from what Julia said on policy, we work towards harmonizing health policies and guidelines, and that's why we are a regional organization, building capacities for human health largely, but over the last couple of years, spread onto to embrace the One Health approach. And of course, also with a focus on strengthening health systems, preventing and controlling communicable diseases and NCDs as well. And of course, working regarding the impact of the health policies programs and budgets. And I was really excited when I spoke about the executive course on AMR policy, which I think is really important, especially in this area, which is relatively new, and we have not been able to monitor the impact of our policies of our national action plans that we have developed. So put this slide here just to try and cover up what one of my colleagues missed yesterday in terms of One Health preparedness and response. And just to bring to us that we, beyond AMR and also leveraging on other ongoing regional activities, we've been able to work on supporting countries to build their capacities on preparedness and response from a One Health perspective. So we have worked on surveillance systems, not just on AMR, but looking at the integrated disease surveillance and response strategies, looking at points of entry, and that is cross-border work. And I think this goes beyond just disease surveillance, and we have a lot of antimicrobial resistance issues that cut across the border. When you look at medicines and the movement of medicines across the borders, how can we leverage systems that have been set to support surveillance of diseases to also extend to supporting other AMR-related aspects? So, and I think the other good component is the mapping of priority public health risks and vulnerabilities. And in my next slide, you will see, even as countries sit together as One Health teams, they've been able to map their public health risks, and AMR has started coming up as a risk that is actually ranked as very high in some of our countries. So giving us an opportunity again to be able to address AMR beyond the national action plans. And that is how now antimicrobial resistance came into this particular response, building in capacity for lab-based surveillance to improve AMR surveillance and also support antimicrobial stewardship actions. So this is like a heat map just showing one of those activities that countries have carried out. And we tried to summarize what across, these are 6 countries, to look at what they portrayed as hazards and risks within their countries. And you can see a lot of these hazards and risks are those that require action from a joint or a One Health perspective. And you can see for AMR, we had Malawi ranking the risk as high, and then we had Lesotho and Rwanda ranking AMR as very high. So which is important because it raises the visibility of the issue within the countries and also at a regional level. When you're able to consolidate all country risks and ranking, then you're able to quickly put together what needs to be a focus, and you're able to bring this to the discussion of the ministers' council, also to the technical leads from different countries. And on my left is I just highlight critical processes that countries go through that also have an opportunity to work around AMR and also mobilize resources for implementations. For example, the joint external evaluation. Some countries are going into their second round of JEE, and we recognize that in the new joint external evaluation assessment tool, the indicators around antimicrobial resistance have been revised. They are now more and a bit more specific, which is a good thing. And once joint external evaluations have been conducted, countries are required to develop national action plans on health security. And we have found AMR as part of the national action plans for health security. So it gives the opportunity for NAPs to be implemented in terms of interventions cutting across multiple sectors. So when it comes to sustainability, I thought I would start on this particular aspect where we had a project that was running in 5 countries, which involved building capacities for laboratory surveillance in 35 labs spread across the 5 countries, as you can see in the map. And this was a project that spanned over 10 years, from 2010 to 2020. And in 2010, we didn't have national action plans on antimicrobial resistance, but some of these countries actually built capacity to begin to carry out surveillance on AMR. And when the national action plans were later endorsed, and one of the strategic objectives revolved around capacity for laboratories, a lot of these labs found themselves in the first phase of implementing the AMR surveillance plans for these different countries, like you're going to see. So the implementation that ECSA has taken in terms of ensuring sustainability, even once projects close, has been that of ensuring we have accountability. We are accountable to the member states, one, where there is regional funding. Number two, the countries come in and define their priorities. And I like what Julia said, priorities are different from every country. Stewardship might be a priority for Zambia, but for Rwanda, maybe it is surveillance. So when the countries define their priorities for support, then at the regional level, we are either able to give them technical assistance or financial support for these priorities that have been defined. And that implementation of the priorities identified is actually done using national capacity. And we have found that this kind of an approach has actually ensured that even once the project comes to an end, the activities continue to run within that particular country. So these are just some of the priorities that we have had over the last, from the 2010 project and span into the newer project that was running on strengthening pandemic preparedness, a focus on antimicrobial stewardship programs and surveillance. And as we carried out support for stewardship and surveillance, we realized where there was weak governance and coordination, none of the other objective areas could run in a well-coordinated manner. So we found that as an overflow, we ended up supporting governance and coordination, which is really like the backbone of any AMR program within the country. And once you begin to touch governance and coordination, by default, you're spilling over into advocacy and awareness, which is inevitable. The moment you start generating data, it needs to be shared at some point, and that happens both within the stewardship and the surveillance programs. So the other bit that has supported the sustainability of action is just harnessing the power of networking and recognizing that every country has capacity that is unique to that country. And I think once you recognize this, you give the countries an opportunity to build that capacity and also provide technical assistance to neighboring countries. That has been very, very helpful. So you can see, like in the previous project, different countries took on different aspects in terms of supporting. Like Uganda was leading accreditation of laboratories, and they have continued to provide that support throughout the project and even after the project. Tanzania was best practice in terms of training and capacity building, and we have continued to use the colleagues from Tanzania to support other countries build their capacity in different areas, whether it's stewardship, governance, or antimicrobial resistance surveillance. So what we have learned is that when we realize that there's such rich experience in every country, we don't limit it within the border. So we have also embraced communities of practice that meet once every year to share best practice and also agree on areas that they can work on in the coming years. And I think that has also kept the work going beyond the projects. So these are just photos of some of the labs that were renovated, and some of them actually built from scratch, and realized that this is not adequate, but it gave the countries a very good starting point, like you can see in this slide, where the initial investments were made by a different project to improve capacity for the laboratories, train and provide mentorship. And what happened is that later on, when we had the glass manuals released and countries began to localize or adapt the glass manuals, these laboratories became suitable candidates for early enrollment in the surveillance networks, and they were able to develop the action plans and rolled out surveillance as a first. And because of existing capacity, and for those that are familiar with the glass system, which requires countries to designate a laboratory, a national reference laboratory, or a microbiology reference laboratory, because of the infrastructure that had been built and the capacity that had been put in place, these countries were able to enroll into the glass system early on. And apart from that, they realized you cannot just have surveillance, you need to use the data. So the stewardship programs were now born out of the AMR surveillance processes. And that is when we had the first edition of a regional stewardship guidance document, which actually took about 2 years to develop. And the stewardship document has actually provided guidance for the countries to develop their own specific stewardship programs. So this was the approach that has been taken in every country, where a baseline capacity assessment has been done using standard tools, both for AMR surveillance and stewardship programs. CDC tools and WHO tools have been used. And it's good to also just mention that at a regional level for sustainability, if there are technical tools and guide documents that have been developed either by WHO, CDC, or other implementing partners, we have found it useful just to build on that. You allow countries to adapt or contextualize global guidance for their own levels of implementation. And the gaps that were identified, were able to build capacity for these gaps, and data that was generated from the capacity building processes or from the baseline assessments were actually used for making decisions. For example, for some countries, the baseline data guided the strategies for surveillance or the national stewardship guidance. Then countries were able to develop these based on capacities that had been assessed and gaps that had been identified. So these are just some results from some countries, and you can see there are areas that were very weak, like leadership. And once you have a weak area under leadership, then the rest of the program cannot actually be sustained. And I think the things that policy dialogues aim to promote, commitment by leadership, I think is critical. And where there's no commitment by leadership, then accountability and responsibility also falls behind. And you can see in terms of the scoring, those two aspects had a problem. And the last area that was assessed was reporting and feedback. Because there is weak leadership, then accountability and responsibility mechanisms. Therefore, even the requirement for feedback within any health facility or even at the national level becomes a challenge. So these are some scores for laboratories. These labs scored fairly well in one country, but in other countries they would be different. But we have a standard set of parameters that are assessed over the many labs in the different countries that we have had working. I think about 36 labs in 5 countries over the last 1 year have undergone the same level of assessment. And that gives you a very good picture of where laboratories are 5 years into implementing their own national action plans. So these are just like outputs of some of the countries in terms of localizing the regional guidance documents. And out of these country documents, each of them are different. And I think that's another thing I'd just like to point out, that many times when you have global or regional guidance, you might think it might fit in every country, but even the regional guidance has evolved. In every country that you go into, there's always something different. And I think allowing countries to just adapt to what works for them is one angle of making the implementation process sustainable. So of course, moving from building capacity to actual site level capacities, where you've done a national TOT and then the TOTs go into their facilities and build capacity at a local level, and they're able to generate their own data and share this within themselves. And this is just Malawi, and I think they've done an amazing job over the last 1 year.
Evelyn, sorry to interrupt you, just 2 more minutes, please.
All right, thank you. I'm winding up. Then you have the country level support that has also happened. And of course, now evaluating where we are in terms of baseline assessment and current capacities. So I will skip to this section, which talks about we are talking about leaving no one behind. And you can see the vet labs in terms of capacity scored really poorly. How much are we in these laboratories? And if we look at my next slide here, we carried out an assessment out of 36 human health laboratories, only 5 were animal health and none under the environmental sector. So you can see the kind of gaps that we currently have in terms of making sure that everyone is on board. So in terms of our sustainability approaches, what are we saying? That we actually need to locally adapt our global and regional guidance. Number 2, how do we ensure that we have long-term domestic funding? Because I think that's where a lot of us are struggling. And because AMR cuts across sectors, we need to strengthen the systems across board. And we also need to integrate AMR into other policies to make sure that our work is sustained. The data that is being generated has to be used and it has to be shared, and we need to be transparent. And of course, that can't happen if we have very weak monitoring and evaluation processes. So we need to build partnerships and also strong coalitions, just like what is happening in the conference this week. So this is my last slide. And I just thought I'd put this out here for people to think about. What is the role of mathematical modeling in AMR in terms of implementing action plans for AMR? What is the role of artificial intelligence, for example? Can we find a point to leverage for prediction, for assessing the health and economic impact of all these action plans and evaluating the effectiveness of the policies that we are developing. I think this is another angle that hasn't been very well looked into, and I'd encourage all the participants to find a way of engaging colleagues in research in this area. So finally, yes, we have made progress, definitely like the DG said, but we all understand that more needs to be done. I end here, and I really want to thank you for your attention and also for just listening through the presentation. Thank you. Over to you, Laura.
Thank you very much, Evelyn, for a fascinating presentation on sustainability. I'd like to invite the three colleagues that are in the room to come up, please, and join me. And Evelyn, if you can stay on screen for a couple of minutes, we're just going to take a handful of questions. So just raise your hand if you have a question while colleagues are coming up. At the back, let's start with you.
Okay, thank you for the presentation. I'll be straightforward. The first question goes to the last presenter, Dr. Evelyn Wesangula. I would like focus on One Health preparedness and response, especially with regard to the laboratories. I felt was much geared to the One Health or the health-related laboratories. Does this organization have opportunities for laboratories that undertake analysis, especially on environmental samples, maybe on aquatic, the other spheres within the One Health circle, that is animal and environmental health? The other question goes to Dr. Kim, who talked about access. My question is slightly different from what you were asking. Is it possible to have, we had a discussion about this problem of access of medicine back in Kenya, and we felt that there are quite a number of environmental, social, livelihood, and other related issues. Is it possible to have government support, or is it free medication the way it is done in the UK, where a patient just needs to go and give a prescription and the government pays for this? Is it possible to have such a system in Africa? The last question is to Julia Bishop. You mentioned about a short course that you're going to next year, but the focus here seems, and your target was on the NAP, on the NAP practitioners, and from our context, NAP is actually done from a One Health approach, where you have environment, health, and the other sectors. But your target audience here seems to be from the health. Is it because you don't have expertise on environment or animal health related courses? Maybe you could highlight on why this short course on policy, and we need actually our policymakers to appreciate